All right. Well, good evening and welcome to Evening Rounds. I'm Dr. Shakeela Faulkner and I'm assistant professor in the Section of Maternal-Fetal Medicine here at the Department of Obstetrics and Gynecology at the University of Chicago Medicine. I specialize in high-risk pregnancies, meaning I take care of patients who have many chronic conditions, maybe have new fetal diagnoses that are discovered during ultrasound, and as well as many of my other responsibilities, I help to co-manage the diabetes and pregnancy program, or our DIP clinic, along with Dr. Dickens, who's an endocrinologist, and a team of dietitians, diabetes educators, and physician's assistants. So today, our session will be focusing on gestational diabetes. We're going to talk about the diagnostic criteria, a little bit of the pathophysiology, how people actually develop gestational diabetes, as well as some of the management and counseling that I think is important for us to be sharing with our patients. This session is part of our continuing education series for our OBGYN nurses and medical assistants. All right, so let's get started. So here, I think important to think about our vision. So, we're here to learn, thank you for everyone taking additional time, but to really expand upon our knowledge so that we can provide better care for our patients. So I don't have any disclosures. So let's start with the objectives. So this is what I hope everyone can kind of take away after watching this lecture, whether it's live or in the future. So I hope that we have a better understanding of being able to identify the risk factors for gestational diabetes, identifying which patients benefit from early screening, being able to explain the steps of gestational diabetes screening to patients to make sure that it's done correctly and that we have good and accurate data. Understanding the definitions of gestational diabetes, how they differ from people who have pre-gestational diabetes, understanding and being able to explain the potential complications. So therefore being able to convey to patients why it's important to do the screenings, why we think about them kind of both in the early parts of pregnancy as well during the traditional 24 to 28 week range. I'm going to talk about how to counsel patients. So really getting into lifestyle modifications, glucose monitoring. Then we're going to go into a little bit more details of just how to describe, actual insulin administration, how to manage hypoglycemia, how to recognize those signs and symptoms, explain the indications for antepartum testing, growth ultrasound, and delivery timing, because as we get into that third trimester, we can, be asking patients to do a lot more visits, ultrasounds, and just being able to express why that's important will go a long way. And then finally, in the postpartum period, explaining why patients, we still want to do additional glucose testing to better triage and give them better guidance on what they should be looking out for as they go forward, either with future pregnancies or just their own health and life in general. And then also looking at the associations between developing type 2 diabetes after being diagnosed with gestational diabetes. So just to start off the presentation, I want everyone to know that primarily we're going to be referring a lot to the practice bulletin. So the ACOG puts out very helpful practice bulletins that kind of summarize our current clinical guidelines. And so there is one on gestational diabetes. So this is the reference source here. And then some of the other resources that I rely heavily on come from the American Diabetes Association, very easily named diabetes.org. So wanting to start off with some of the background. So the prevalence of gestational diabetes in the United States is approximately 6.9 to 9%. There's a lot of variation in those numbers, in part because of the variation in diagnostic criteria. And so you'll see a range, but predominantly that is the quoted range. But you'll see as we look forward into some of these different charts and graphs that there's a large disparity based on many different demographic factors that I think are important when it comes to counseling patients. So some of the important risk factors that we think about are age, BMI, sedentary lifestyle, family history, race, and ethnicity. So just looking overall and kind of how trends have changed over the years, we can see that there is kind of a steady rise with a quite steep increase after 2019. And these rates are per 100 births. So you can think of it as just straight percentile. And this is kind of landing around like 7.75. So within that range that I mentioned before. Now, if we start to look at other criteria here, we're looking at the kind of differences by age. And you can see how if you simply say 9%, that works for some people, but as you get into our patients who are certainly over the age of 35, much higher percentages of gestational diabetes, and they're rising from year to year. This graph here is comparing 2016 in the light color to 2021 in the dark colors. So again, important when we're quoting patients their risks that we, as best we can, look at the data that best fits them. Here, this graph is looking at the difference based on BMI. So again, 7th percentile probably fits with the overweight category, but once you get into patients who are meeting criteria for obesity, that does significantly increase. Okay. Now this slide I think is really important because it does get into differences by race and ethnicity. And now I don't think we know enough to figure out what the actual root cause is, whether it is systemic racism and access to care, whether it is, cultural differences in food, sedentary versus physically active lifestyles. So I don't think we can really dive too much into that, but we can look at making sure we screen people according to our data that shows patients may be at higher risk than what would otherwise suggest based off of their age or BMI. So here you can see this is coming from our national vital statistics. Black, non-Hispanic, non-Hispanic, white are around the 6.5 to 7. Hispanic rises a little bit to 8.5. And then as we start to get into these top 3 groups here, I think to me it's also important because I think these are racial and ethnic groups that aren't always, separated out. I think sometimes in research, people's groups get collapsed because we feel like we don't have enough numbers or enough to kind of make conclusions. But I think there's potential harm when we do that because you lose the fact that these patients may be at higher risk and aren't being counseled otherwise. So I do appreciate that kind of both of these studies really try to separate people out as much as we could to see if there were actual differences at a more granular level. And so here you can see this is non-Hispanic, Native Hawaiian, or other Pacific Islander. This is non-Hispanic, American Indian, or Indigenous peoples. And then here we have non-Hispanic Asian at the highest, reaching about 15%. And then this is kind of similar level of granularity, just a different study. It's per 1,000, so it's if you just move the decimal, it would mirror fairly closely to that previous chart I described. But I think it's interesting here because they do actually break down non-Hispanic Asian groups, and you see Asian Indian kind of at the top here, and then breaking down by other countries. And then similarly with Hispanic, they broke down different countries of origin as well, but you can see there's quite a large spread. So again, it's not going to be the thing that drives all of our counseling, but it is interesting to think about when counseling patients. The other things, comes into access, cultural norms, cuisine, things like that, is to look at just geographically how there are differences across the states. So we can see here we're Illinois, our rates fall into about 9 to 9.9%. You can see fairly similar to some of the Midwest states, but we're not the best in terms of managing our rates of gestational diabetes. And then this image here, I think, is interesting because it shows how things have been changing between that 2016 and 2020 kind of milestones. And so we fall into the category where we've risen by 30 to 39%. And I would say, unfortunately, most of the country has increased fairly significantly. I think only these few blue states have had less than a 20% rise in gestational diabetes or no rise at all. Okay, so definitely an issue that affects many patients, and unfortunately at this time it is getting worse. Okay, so next we're going to look at the definitions of gestational diabetes and compare them to pre-gestational. So the ideal is that we have patients who have been in care, have had assessments if appropriate to assess for gestation for type 2 diabetes, so that when we notice glucose intolerance in pregnancy, we can fairly confidently say that this is truly gestational diabetes. And then we would separate those two into categories with GDMA1 or A1 GDM. which would be diet controlled, meaning that simply changing nutrition, changing exercise is sufficient to bring the glucose levels back into goal. Contrast that with GDMA2, which means that medication is required in order to provide that same level of control. Contrasting this, pre-gestational diabetes is, really we need to diagnose it outside of pregnancy. I think there's certainly criteria where we can use to say this is highly suspicious, but typically we still often will repeat testing after people are in the postpartum period. And some of the criteria that can be used is an A1C greater than or equal to 6.5, a fasting glucose greater than 126, a 2-hour oral glucose tolerance test with a 75 milligram load with a 2-hour test that's greater than 200, or if a patient has a random glucose of 200 plus symptoms of hyperglycemia, so increased thirst, increased urination, things like that. And then pre-diabetes, if you ever see that noted on a chart, is an A1C that's between 5.7 and 6.4, fasting glucose between 100 and 125, and then that same 2-hour glucose tolerance test, but with lower levels of 140 to 199. And then finally, type 1, which is fairly different and separate, but I wanted to still include it on here for completeness, is an autoimmune condition that's really targeting the beta cells of the pancreas and disrupting the body's ability to produce insulin. So it's more of a lack of insulin rather than insulin insensitivity or resistance, which we see in kind of the other forms of diabetes. So now I think it's important to talk about how glucose and metabolism normally changes in pregnancy, because what I often will tell patients is that everybody's body is kind of designed to lean a little bit towards a quote unquote diabetic state because the fetus uses glucose as an important energy source. Okay. Fortunately, despite how long we've been studying diabetes in pregnancy, the exact hormones or factors that lead to gestational diabetes is unknown. We certainly know people who are at higher risk factors, but we don't know the exact mechanism that would determine whether or not someone is going to develop gestational diabetes. But this is just kind of an overview of what the normal kind of pathology or physiologic changes that we see within pregnancy. So early in pregnancy, we do see that the glucose levels will drop, in part due to the fact that there is increased blood volume, which is why sometimes you'll see an A1C is a little bit less reliable than a person who is non-pregnant. Then as we go throughout the pregnancy, we can see an increase in glucose production for fetal utilization, especially as we enter into the 3rd trimester. And so this will lead to decreased fasting glucose, because you can imagine, even when you are resting, sleeping, not eating, the fetus is still utilizing that glucose. And so ideally, your blood sugar is still going down. To balance out the fact that there's increased utilization, there's an increased glucose production from the liver and decreased insulin sensitivity to try to leave a little bit more glucose kind of in your bloodstream, in your system. And we can see this reflected in increased postprandial glucose. So this is, the natural change that should happen in every pregnancy. The problem is if there was pre-existing metabolic dysfunction, often patients who have metabolic syndrome, elevated BMI, these normal changes can kind of tip patients over into gestational diabetes, meaning they're not quite able to regulate with their normal glucose and insulin hemostasis. So now let's get into screening. Who do we need to actually assess for gestational diabetes and when? So based on, the research in the past, we've determined that it's important to screen everybody, even those people who have essentially low risk, no family history, no prior history of gestational diabetes. Everyone should still be evaluated between 24 to 28 weeks of pregnancy. The early screening is really what we're trying to determine is, could people have actually had pre-gestational diabetes or really early gestational diabetes that really needs to be monitored, have close follow-up, and potentially will need, insulin management early on. Potentially, even if we think people have early gestational diabetes, sometimes we will manage them very similar to patients who have pre-gestational diabetes, which comes with additional evaluations like fetal echoes and things of that nature. So it is important for us to identify who should have these tests as early as we can. So ideally, we're doing this screen at the initiation of prenatal care. And we're looking at patients who have risk factors, and there's multiple ways to go about this screening. So we can use the two-step approach, which is similar to what we use at the 24 to 28 weeks. Of note, this is not used in non-pregnant patients, so we don't really have a parallel to, type 2 diabetes diagnosis, but we often will use it to say that there's some amount of insulin insensitivity. And then finally, you can also use just the type 2 diabetes criteria. So the A1C greater than 6.5. Usually in pregnancy, the A1C can be falsely lowered so that if you're still reaching, type 2 diabetes cutoffs, you can be fairly confident that if anything, it's actually a little bit higher than what you're seeing. And then again, the same criteria used for type 2 diabetes. So there's fasting above 126, the 2-hour greater than 200, and the random glucose with 200, non-fasting that has symptoms. And then here we'll see this, sorry, this comes from the ACOG practice bulletin looking at which patients should be screened. And so interestingly, they actually do make a distinction, recognizing that Asian Americans do seem to have higher rates of gestational diabetes. And so they suggest that you should consider screening them at a lower kind of BMI cutoff. So rather than using that 25 that indicates overweight, to actually lower it to 23. And so you want to think about screening patients with either with an elevated BMI plus any of these other factors. So decreased physical activity, first relatives with diabetes, if they fall into any of the higher risk ethnic groups, a prior fetus that was above 4 kilos, any prior history of gestational diabetes, high blood pressure, elevated HDL. So kind of you want to keep your highs high and your lows low. So sorry, in the reverse. So if your HDL is low, or if you have elevated triglycerides, people with polycystic ovarian syndrome, anyone who meets criteria for pre-diabetes, and then any other factors that are kind of associated with like metabolic syndrome and a history of cardiovascular disease. So next, let's look at what that diagnostic criteria looks like. So most often we are using the two-step method. There is the option for a one-step method with the 75 milligram load, but that's typically not commonly used. And so I'll go through here the two-step method. So first, you will do the 1-hour glucose tolerance test. There's 50 milligrams of glucose. Important that this does not have to be fasting, so this can be, just ordered at the end of the visit. And you're looking for an elevated value, which can range depending on institution from a cutoff of 130 all the way up to 140. If that value is elevated, then the recommendation is to proceed on to a 3-hour glucose tolerance test, which is done fasting. And then it is a 100 milligram glucose load. And then if there are 2 elevated labs within that 3-hour test, then that would be considered diagnostic for gestational diabetes. An alternative, if their 1-hour glucose tolerance test has a significantly elevated glucose, meaning that it's over 200, you can get a fasting glucose, and if it's over 126, which is part of that criteria to diagnose type 2 diabetes, you can fairly reliably say that that patient meets criteria for gestational diabetes. So this is kind of getting back to what I said, why it's difficult to know how common gestational diabetes is to compare different studies, because there are definitely differences in the cutoffs that are used, which impacts who gets diagnosed, who gets treated, et cetera. So there are, for the 1 hour, there's 130, 135, 140. We often will use 140, but it is not incorrect to use a different cutoff. Really, the goal is that it should just be standardized across the practice, to make sure they're being consistent. And then for the 3-hour, there are also 2 different sets of cutoffs. We usually use this one here, the Carpenter and Houston. And so that this is why it's important to have fasting, because it is part of the criteria. So it could be any 2, the fasting, as well as any of the 1, 2, or 3-hour marks. And this question comes up fairly often. If a patient needs to use the 3-hour during the early screen and ultimately is normal, what should be done at the 24 to 28 week screen? Again, not set in stone, but it is reasonable to just proceed directly to the 3-hour at that later screen. Again, if you or the patient wants to restart at 1 hour, that's also reasonable, but you can reasonably skip it as well. Okay. So the risk and complications. So again, I think this is where a lot of the counseling really starts, which is helping people to understand why this is important, why we, to even put in the time to do the 3 hour, because it can be inconvenient. People are hungry and things like that. And so I think it's important to explain the why. So these are the conditions that we often think about. So increased risk for macrosomia or a large for gestational age baby, increased risk for shoulder dystocia, which I'll go into a little bit more detail later. Increased rates of cesarean delivery. So one study showed that controls had a rate of about 9.5%, GDMA1, who managed just with nutrition changes, 17, and GDMA2 had rates even close to 25%. Again, varies across studies, but it just kind of shows almost like a dose response based on people's insulin sensitivities. We can also see neonatal hypoglycemia, meaning that the baby, once they're delivered, their blood sugar actually goes low, which is not safe. I think for all of the counseling that we give, I think it's always important to stress that hypoglycemia is the more dangerous form. Hyperglycemia, you have a lot more buffer room before you are in a dangerous state, something like DKA or something like that. Same is true for baby. Hypoglycemia can be quite dangerous as well. Hyperbilirubinemia. This is when you think of babies needing the Billy lights, things like that, because they're actually generating quite a few like extra red blood cells in response to that increased sugar. And then as they break down, they end up with increased bilirubin. NICU admissions in order to manage these conditions, then increased rates of miscarriage, usually early on, and then stillbirth as you're entering the third trimester. Especially those for poorly controlled diabetes, people who almost mirror that of like a type 2 picture that can really have an increased risk for stillbirth, and then preeclampsia. So one study showed that patients with lower fasting glucose had a rate about 9.8% compared to those with higher fasting glucose up to 18%, so almost double. But they also showed that with treatment and kind of normalizing of those blood glucoses, we could get people down to more like 12%, which is much more similar to the controls. And then thinking about long term, we can see increased rates of diabetes in the child, actually, in both childhood and adult onset diabetes. So just going a little bit more into shoulder dystocia, because I think, we kind of in the one category I think we talk about a lot is babies being on the bigger side, but it also has to do with the fact that distribution, they tend to hold a little bit more weight kind of in their shoulders, in their torso, rather than it being well distributed. And that can increase the risk for shoulder dystocia, meaning that the head comes out and the shoulders and body don't easily follow. And the concern or risk that come with a shoulder dystocia is that in the attempts to deliver, strain can be put on the neck that could potentially injure the brachial plexus, which is this complex of nerves that go kind of through the neck into the arm. There could be potential risk of fracture of the clavicle, as well as decreased oxygen, right? The baby's being compressed during that time frame. Babies can have significant complications to the brain, sometimes even be the point where, significant morbidity and even mortality can result from a shoulder dystocia. In addition, there can be injuries to the pregnant person as well, just in trying to do the different maneuvers necessary to deliver the baby as quickly and safely as possible. So certainly lacerations or injuries to the surrounding structures, hemorrhage, well, this is kind of delaying the delivery of the placenta, or injury to their nerves as well. So just to go in a little bit more detail, when I talk, I actually go make sure when I'm talking to patients about their risk of shoulder dystocia that I go into what it is, because a lot of people, unless someone's experienced it, they don't really know what that is. And then also to go a little bit further into neonatal hypoglycemia, this is just kind of a diagram to explain why and how that happens. So if the pregnant person has elevated glucose, glucose does cross over the placenta. And so then the fetus in response is going to be increasing their own insulin production in order to kind of normalize the glucose within their own system. After delivery, you no longer have this connection of the placenta. However, there's a delayed adjustment in that insulin production. And so you still can have elevated levels of insulin. And so when the baby is born, it has more insulin essentially on board than it needs and becomes hypoglycemic, and it can just take time to adjust. And so often babies, if the patient has gestational diabetes or any pre-gestational diabetes, those babies are getting frequent glucose checks to see if there is evidence of hypoglycemia and if they need additional assistance. And so we focus a lot on optimizing intrapartum glucose in order to reduce that complication. We won't go too much into that today, but certainly when counseling patients, we do let them know the importance of optimizing not just in the moment of delivery, but honestly, the days leading up to can also be beneficial because, as you imagine, our bodies don't necessarily flip a switch, in the matter of moments. It's kind of we get to a steady state over time. So it's best if the patient's glucose is fairly normalized even in those days leading up to, and not solely relying on manage intrapartum with insulin. Okay. All right. In terms of glucose monitoring, these are the targets that we aim for. So for fasting, we want the blood sugars to be less than 95, 1 hour postprandial less than 140, 2 hour postprandial less than 120. And often the glucose logs will look something like this: dates with their glucose readings. If they're on insulin, there's usually a spot to write their insulin as well, and then notes. I find the notes particularly helpful for patients to indicate, a reason why their blood sugar was a little off target, either too high or too low, because then that can give context to, whether adjustments actually need to be made. Do they actually need to be started on insulin, or, did they, have a party or something like that? They had additional snacks, and, it's kind of explained by their dietary change. It's not going to be a persistent trend. So here we go just a little bit about how glucose monitoring is done. Certainly we are checking in the clinic, but it's also important once patients have their meters that we kind of go through teaching with them there and kind of explain, depending on their insurance, depending on the pharmacy, kind of depends on which actual company will produce their glucometer, and there's lots of good resources online. So often I will tell patients to look at their manufacturer's website or go on YouTube to look for information and troubleshooting, in addition to, certainly reaching out to the clinic. So again, kind of important things we always tell patients: make sure you clean, wash your hands, ideally have like an alcohol prep that you can also use to clean off your fingers. Then adjust the lancet. Over time, patients will have a sense of, the depth of the lancet that they need to in order to get that actual drop of blood, and then make sure that they touch the tap strip to the drop of blood in order to make sure that it actually fills that little well. And then the meter will often tell them if it's sufficient or if it needs to be done again. Think of really important things. So using the sides of the fingers, I think this varies. I've definitely seen people who will use the side of their fingers as well. ADA recommends not over squeezing the finger, and then also making sure that the battery is working well, not to use expired strips, don't leave them in extreme temperatures, things like that can also be helpful. Okay. I have a video, but we'll see how we're doing on time and if people are interested in it just seemed to be very good and like stepwise, because I think a lot of times the glucose monitors that we use, the glucometers we use in clinic don't actually match what patients have at home. So sometimes it's a little bit tricky to troubleshoot them specifically. All right, so that is your traditional glucometer. You have to prick your finger every time to get a reading. I did want to talk a little bit about continuous glucose monitoring, because that is something that we're seeing more commonly used. People are buying commercial CGMs to get their data. And so I wanted to talk a little bit about that. And I think over time, maybe something that becomes more widely used in our clinics as well. So basically the way that a continuous glucose monitor works is that they have basically it's like a wearable device, I'd say a little bit bigger than a cord or size, depending on the manufacturer, and it allows a patient to read and monitor their blood sugars without using lancets. Depending on the type, You sometimes have to bring like the detector or your phone close to the sensor. Others are continuously transmitting information to the app so you can just see it in real time. It is nice because in addition to being able to view the numbers themselves, data can also be shared with families or friends for both safety and accountability. I've encouraged patients to do it for both reasons. And it can also be shared with the clinic. So, it certainly increases the chances that you have data to kind of discuss during the visit, have real-time information and information that sometimes would get missed, because we only check at certain time points, but maybe there's lows happening in between or even higher spikes than we're realizing. And so it can be helpful to use for that reason. It is important to know the caveats and the differences between them. So the CGM, it's basically like a thin plastic catheter that sits, it's measuring in interstitial fluid. So it's between the cells. It's not actually measuring the patient's blood. And so the numbers can actually be different. And we tell patients in advance that they're going to be different because otherwise, people who are used to using glucometers have a sense of how their different diet and meals are affect their blood sugar, can be thrown off by the fact that the numbers are different. So I thought this graphic here was pretty helpful in explaining. So if this kind of, the gray line here is basically referring to how the blood sugar is. So if it's pretty steady, stable, then both the sensor for the CGM and a glucometer will give you about the same reading. The problem is going to be when there's rapid changes, so either rapid rise or rapid decrease, that the sensor is going to lag behind. And so that's why if ever patients see, a really high or really low number, we also recommend just using a glucometer to double check because it's going to be more accurate as to what's happening. So that is another important thing that patients know, that just because you have a CGM doesn't mean you shouldn't also have a glucometer available to you that you know how to use, because it may malfunction, but sometimes there's going to be extreme numbers that need to be cross-verified. And then just briefly, this is kind of how some of the reports, they talk a lot about target time and range, which is sometimes pregnancy goals. It depends on kind of the product that you're using, but basically it's a nice image that can summarize for you and the patient how often the patient spends in different target areas. All right. So getting into nutrition, exercise, it's really kind of the starting point for everyone in terms of how to manage their blood sugar before we're thinking that we need to use insulin. So I think the education and nutrition, I think, is really important, is identifying carbohydrates. Not everybody has an understanding that carbohydrates break down into sugar. Some people don't know what carbohydrates are. And so I think really kind of spelling that out for patients. There's a lot of good websites online that kind of have both pictorial, both lists and things like that, shopping lists that can be really helpful. Reading nutrition labels, I think, is another skill that not everybody has. People haven't really practiced. And then again, looking at both the carbohydrates and the total sugar and the added sugar and things like that. Meal prepping, one of the things that can be challenging and frustrating sometimes for patients is their blood sugars are different every single day for every breakfast and every lunch. Part of that has to do with varying amounts of carbs and proteins. And so I think helping patients to get a sense of what is a good meal that will keep them fairly, in range, and trying to replicate something similar to that or that exact same meal on like a rotating schedule can be helpful. And then portion sizes, because even when we talk about what is, like a better carb to use, more complex carbs, if you're still consuming a lot of it, you're still going to run into episodes of hyperglycemia. Counseling on ideal weight is also, important, kind of goes along with this, just so patients have an idea. I think one of the things I think are important to stress is that a lot of your weight gain really should be shifted towards the end of the pregnancy. So if you're seeing patients that are gaining a decent amount of weight in the first trimester, definitely a time to kind of sit down and like just talk about that trajectory. And so this comes from ACOG as well, and kind of breaks down how much the recommended total weight gain for the entire pregnancy by BMI. But I like the pounds per week column because I think that's a little bit more tangible for people to think about rather than saying like, oh, I've gained 8 pounds already. I only have 12. I think this way people can have a better sense of this is what I should be in this range for this week. And then next is exercise. So this is the same for everybody, all pregnant people. The recommendation is to try to get 150 minutes per week or 30 minutes per day, 5 days. And it's been shown to improve pregnancy outcomes, even for patients without gestational diabetes, but particularly with those who do have diabetes, it can help your body in terms of metabolism and your insulin sensitivity. So just going into some of these images that I think are really helpful. So kind of going into portion sizes. So this is using a 9-inch plate, which is not the size of many people's dinner plates. And then showing how to break it down by non-starchy vegetables, protein, and then your carbs in the smaller section. Certainly stressing the difference between vegetables and fruits, even though we think of them kind of the similar area of the pyramid, fruits are going to often have much higher amounts of sugar. And so helping patients to understand kind of which things have a higher glycemic index can be helpful. This is getting into more planning and preparation. So to plan out food in advance, prep your food once, eat twice to make it even easier, right? So patients can make things in bigger batches if they're able to, and they kind of already know this will not, cause me to have a significant spike, and then kind of find a rotating schedule, have a grocery list so that you're shopping with intentions, and then reading the food labels. And then here again, this is coming from the ADA. And so I think, again, it's a really nice way to look at all the different components of the nutrition label and kind of understanding how they break down that fiber also falls under carbohydrates. And so very quickly, things that we think are not that sweet actually can have a decent amount of carbs. This here, I wanted to talk a little bit about insulin so that we have an understanding and so that we can also help explain to patients a little bit more. So often we break things down into long acting and short acting. There is intermediate acting, and so I'll go into that because I do know that some of our providers do use NPH. But in general, your long or your intermediate acting insulin are going to cover your fasting or your preprandial values. So if patients are having high blood sugars when they wake up in the morning, then often we're going to increase that long-acting insulin in order to try to bring those levels down kind of across the board for the day. And then short-acting really is covering meals. And so here we can kind of see Lispro, Aspart, those are the most common short-acting ones. It starts acting within 5 to 10 minutes, peaks in about 30 to 90 minutes. And then Glargine or Detamir is your long acting. It starts about 1 to 2 hours. It never really peaks. It just kind of ideally has a nice longitudinal coverage. And then NPH, because some people do use that, it's more of a 12-hour coverage. So you can decide to use only kind of for the morning, the evening, or different amounts. So that's one of the nice things about using NPH is that you can kind of give a different amount of fasting coverage for the daytime separate from the nighttime. I think from a safety standpoint, it's important to teach patients the difference between their short and their long acting, because short acting is going to give them a very quick spike. And so it is important that they eat after giving the insulin. Sometimes patients forget, they get distracted, patients fall asleep, and that can actually cause them to be hypoglycemic. So it is important that when they're getting ready to give their insulin, that their food is actually essentially ready. I've had patients, administer insulin while they're still preparing, and things can always just take longer than expected. And so you do risk episodes of hypoglycemia during that. And then addressing hypoglycemia. So really, if the blood sugar is going less than 65 or 70, we want to be talking to patients about how to correct that and bring that up. So some of the symptoms they may experience: sweating, dizziness, feeling cold, kind of clammy, headaches, shaky or confused, feelings of anxiousness, nausea, or blurred vision. In really severe cases, it can result in altered mental status or even seizures. So also helpful that family, friends, coworkers are also aware of these signs, especially in these more severe cases. Then in terms of management, there's a really helpful 15 by 15 rule. So you should eat or drink 15 grams of fast-acting carbs and then recheck the glucose 15 minutes later. And if it's not improving, to then consume an additional 15 grams. And then again, kind of reasons why this may happen, ways to kind of caution patients against doing this is administering the insulin and not eating or eating less. So I think it is important for patients to think, am I actually going to eat all the food that I plan? Am I going to eat a full dinner? If not, maybe take half. Again, it's always safer to be hyperglycemic than hypoglycemic. And then if there's changes or inconsistencies in the food, so if we're eating lots of meals or high carb meals, and then you bring those numbers to your appointment, your insulin is adjusted based on that. And then the following week, you eat things drastically different. Again, if they're trending towards being healthier choices, that's great, but important to kind of reach back out to the clinic so adjustments can be made for the insulin, or maybe you check your blood sugars, more often, so you know kind of how to adjust. And then changes in exercise. So if you have a more active day, that can also cause your glucose to go lower. And so here's just an example of kind of fast-acting carbs. It's actually 15 grams is quite small. And so, a tablespoon of honey, 4 ounces of juice. So this is often like the juice cups that we have most of our clinics in the hospital. They're usually 4 ounces. I put these down here because these are common snacks that we have around. So just so we know so the small goldfish is about 19. A small pretzels is actually 47. So it is quite high. So it is important that when we're trying to correct people's hypoglycemia when they're with us in clinic or in the hospital, that we kind of give them a smaller portion or close to that 15 grams. Otherwise, we can overshoot. And then you're kind of chasing after needing to manage with insulin as well. Okay, so kind of team approach to care, kind of how everybody's role kind of fits in. So I think with our, the medical assistants in our clinic, screening for symptoms of hypoglycemia during that initial triaging, kind of obtaining the glucose logs, figuring out where the patient has them, if they're on their phone to pull them out, because it just helps to, really prepare the plan for when we go in to talk with the patients. Getting a point of care for glucose really depends on the situation. So if a patient is hypoglycemic, of course, if there's forgotten logs or there's lots of gaps within the logs, then it is also helpful to have a point of care during the visit. Then the urine dip, I think providers will vary on whether or not they want those. But you're looking for is there's increased glucose and then ketones. Ketones is more so going to be for patients who are essentially almost in that type 2 range. It's not too common that you're going to have patients with only gestational diabetes that are going to start spilling ketones, but basically that is screening for DKA, which is a more serious complication that does need to be managed in the hospital. And then in terms of the nurses, again, I think it does vary by clinic setup. And so, but often a lot of the glucose monitoring education on nutrition and exercise, insulin teaching, triaging the patient questions, helping to review the glucose logs, fielding initial questions. Patients may just ask, should I go up? Am I in a good range? Can I continue? I think, just speaking with the provider that you work with, is it reasonable for you to kind of make that call? Do they want all the questions to kind of come through them? And then following up with the patients who are having more challenges. And so I find this extremely helpful because sometimes patients need a lot more just communication to check in. Did you get your glucometer? Are you monitoring? Can you send it to us through my chart? All of those things to just make sure we keep patients as healthy as possible. And then there's other resources available, so dietitians. So there's certainly a couple of sites that do have dietitians available who can provide additional counseling on dietary changes, diabetes educators, so have a little bit more additional training on counseling for nutrition, insulin management, and education as well. Endocrinologists, so through the DIP clinic in Hyde Park, we do have Dr. Dickens who helps to co-manage patients who are needing insulin. Then certainly the prenatal providers. Everyone has their own different comfort level in terms of managing insulin, managing the antepartum and delivery recommendations, and then finally MFM. We're always happy to be available for consults, co-management, or transfers of care. Okay. And then just getting into prenatal surveillance and kind of what that looks like. There's A1 GDMs, because everything is nutrition controlled, there's a little bit less clear recommendation, so it's more institutional dependent, but you can start antepartum testing between 36 and 40 weeks. A2 GM, typically we are starting at 32 weeks, and that's with weekly testing. Here we use BPPs, other places will use NSTs. I think both are appropriate. In terms of growth ultrasounds, again, more provider discretion, but certainly reasonable for anyone with gestational diabetes. You at least want some assessment in your third trimester. With A2 GDMs, we typically will manage more similar to type 2 diabetes, in which we'll get every 4 weeks, we'll get a growth ultrasound. And then delivery timing all comes down to control. So A1 GDMs, you can go 39 weeks to 40 weeks and 6 days. A2 GDM, that's well controlled, 39 weeks to 39 and 6. And then A2 GDM, that's poorly controlled, individualized. So often it's going to be more like shared decision making of, we obviously want to balance out the risk and benefits, but at some point the risk of stillbirth do start to increase when you have really poorly controlled diabetes. And so certainly when you're getting that early term time frame, it is reasonable to think about delivering 37, 38. Okay, and then finally, I just wanted to look at postpartum glucose screening. So about 15 to 70%, wide range, but a sizable amount of patients with gestational diabetes will develop type 2 diabetes at some point in their lifetime. So at minimum, patients should be screened every 1 to 3 years. So again, really important to stress the importance of PCP and primary care follow-up. And then the postpartum glucose screening is really helping to determine, if patients actually have type 2 diabetes. Remember, there's a cohort that had their early screen and maybe was found to have an abnormal screen, but until people are postpartum, it's always kind of possible, likely type 2 diabetes, but it is helpful to have that test kind of outside of the pregnancy state to confirm. And then oftentimes we would look at both the postpartum day 1 fasting glucose, and then 4 to 12 weeks we'll do the 75-gram oral glucose test, which is also fasting. And so here we have this flow chart from ACOG that kind of breaks down what should happen. So normal result, really should still be having an assessment every 1 to 3 years, continue counseling on physical activity, weight loss, nutrition as is appropriate. People with kind of middle range values, 140 to 199. This is still considered impaired fasting glucose or glucose tolerance. And so it's still worthwhile, again, referring to a PCP that's going to keep a close eye on it because they're at higher risk for tipping into the criteria for diabetes. Then I would leave this typically more to their primary care at this point, but whether or not they want to start metformin and things like that. And then finally, if either of those tests are abnormal, then it'd be reasonable to now diagnose a patient with type 2 diabetes and then refer appropriately either to primary care or endocrine to help with that management. Okay, so just summarizing some of the take-home points. So there are normal changes in metabolism that really are designed to increase the amount of glucose available for fetal utilization and kind of decrease our insulin sensitivity. However, if you have pre-existing metabolic dysfunction, then there's increased risk of developing gestational diabetes. Patients at high risk of pre-gestational diabetes should be screened at the start of their prenatal care. We want to universally screen everyone from 24 to 28 weeks. Education on nutrition and exercise are really critical to managing glucose. And then we want to make sure from a safety perspective that everyone is taught the signs and management of hypoglycemia. And then remembering that up to 70% of patients with gestational diabetes will develop type 2 diabetes in the future. So it's really important to have that postpartum screening and primary care follow-up. All right. Well, thank you very much. That was everything that I wanted to share with you guys today, but happy to take any questions. If people want to talk more about actually starting insulin or how we manage that, happy to answer those questions as well.
I think there were 3 questions. Let me just follow up. So,
Yeah.
I don't know if you saw them.
Oh, okay. Yeah.
How do we counsel patients who were
Have hyperemesis and
sorry,
gestational
yeah, I'm
diabetes.
my screen went blank for a second there.
Yeah. Yeah,
Are you
okay.
seeing the questions there?
Yes, I can see
Okay,
them. So
perfect.
I think with hyperemesis, I think if patients can't tolerate the glucose tolerance test, either for nausea, vomiting, if patients who have had bariatric surgery, in which case it would be unsafe because it could cause dumping syndrome, we would recommend monitoring their blood glucose for a week and then kind of assessing those numbers then. Especially, and then the other options, especially if we're talking like more of an early screen, you could use the A1C, you could use the random or a fasting glucose and do that initial screen that way. But if you're getting into that 24, 28 and people are really having persistent nausea, vomiting, then often I would offer the just to screen with a glucometer at home. Okay. And then, okay, yeah, if we have time, we can look at the videos and could scroll back to those. Okay. And then again, this is just one company, but there's many, but I thought this was a very good description.
You'll be able to send me the link for this as well, and I can send it on.
Oh, no sound.
Yeah.
Interesting. I can try to play it louder. Um, let's see. Either I'll play it louder or I can also narrate while it's on. Still nothing?
Still no
Okay.
sound. Yeah.
Okay. I'll just kind of describe it as you're going through. Input. So this is just stressing the importance of the orientation of the test strips before you put them into the monitor. And then once it's in the monitor, you should actually have some type of indicator that it is working appropriately. Again, it'll depend on the device that you're using. This is here is showing the Lancet. And so there's going to be again, different numbers that indicate the depth of how deep it will go into your fingers. So kind of assessing, softer hands, rougher hands, but also I think just trial and error. They often suggest to pick kind of middle of the road numbers initially to start. And so you kind of twist it off to expose that lancet at the top. You put it inside the device and then you kind of replace the cap. In this one, you have to kind of like load the plunger. Again, everyone's a little bit different in how that goes. Then she's adjusting to the level, clean your finger with the alcohol pad. And then you're just going to apply to the finger and then press that button to deploy. See if there's closed captions. There we go. Um, and so they're wiping away that initial drop of blood, and then they're taking the test strip to pick up that second one. Then this one kind of counts down as it's processing, and then it should give you an actual reading. Sometimes there will be error messages that come up, and so important to kind of look at the manufacturer's instructions to know what those errors mean. And this is showing how to dispose of the lancets as they are sharp, so you can kind of put them back into that cap and then have a sharps container that often are available at the pharmacy. And then taking away this test strip, discard it, and then it turns off after you're done. And then this is basically just going through the fact that the devices are nice because it does store your averages, and so you can go through them. Often we can download them into Clinic, and so we can import them into the visit. Okay, and then I'll pull up the second one. Mhm. So this one is going to be looking at kind of the actual administration of insulin. And so they do vary. Often we try to get patients the insulin pens, which basically have, kind of the insulin already in the cartridge, but then there's also the option to kind of draw up insulin with like needle and syringe. And so this demonstration is going to be using a disposable insulin device. So basically once it's empty, you toss it away and then um, you get a new pen altogether. And so just discussing that there's different types of insulin. Some are clear, some are cloudy. And so if it's cloudy, that you do have to mix it back and forth. And then this is the needle that needs to be attached to the top of the actual insulin pen. Again, none of the sharps should ever be reused, and so you'll get a fresh one each time. The different places that you can inject on the abdomen, on the sides, outer parts of the legs, and also on the buttocks. I also tell patients all the time, the abdomen is still safe in pregnancy. It's a very, very shallow needle, and so they can still safely do that during their pregnancy. And that you also do want to rotate the sites for injection because you can start to form like small scarring, which can not only sometimes be painful, but can also disrupt the distribution of insulin. So here she's kind of taking off the cap and then adhering it to the pen and screwing it in place. And then removing the cap. And then there's a smaller cap within this particular device that then actually exposes the needle. So then when you're getting a fresh pen, you do want to, they dilate basically up to 2 and kind of basically like get rid of any of the air that's at the top so that when the patient actually starts using the pen, they know that they've gotten the full amount of insulin and not potentially underdosing because it's a new cartridge. So once they've done that, you see the insulin come out the top, then you can now adjust it to whatever the dose recommended by your provider. And it's basically like a rotation, so you can kind of clicks for every unit, and then you can also see it there showing up through the window. So she basically explained the fact that you don't really have to pinch the skin because it's so superficial. It's really just going in the subcutaneous tissue. You can just pick an area and deploy, and then you're going to press the plunger all the way down and it basically clicks all the way down to 0. And then you want to hold it in place for about a count of 10 to make sure that all the insulin is actually been injected into the skin before you remove it. And now at this point, it's about how to dispose of the needle. So for this particular device, there were kind of those 2 caps. So the larger cap is what you want to use to safely remove the needle, not the tiny one that just was over the sheath of the needle, because that is higher risk for injury. But you can put it on the cap, unscrew it, and then dispose of it in the sharps. And then the rest of the video is kind of just going into the fact, how the pens are displayed, are dispensed, sorry, to keep them at room temperature once you're using them. And it can stay at room temperature for about 4 weeks. And then the others, you can keep in the fridge, but you don't need to kind of go back and forth. But again, it's always important to stress to patients, look at the specific device or pen that you've been prescribed, and then make sure that you're following those manufacturer instructions. Let me see, is anything else in the chat? I think those are the only questions.
Thank you,
All
Dr.
right.
Faulkner. I'm going to go ahead and
Well,
display the
we just
CME
wrap
code
up
for,
then.
I'm sorry. I'm going to display the CME code so everyone who watched the video can go ahead and claim that credit because that is important as they need to see, to see that credit there. So give me just a second. And then any other closing comments or questions? Anyone? Dr. Christmas, do you have anything?
No, that's okay. Yeah,
Okay.
Excellent job. Thank you.
Of course, of course. Happy to help, happy to provide some more information about gestational diabetes. I think one common question that often comes up is when to start patients on insulin, and how to counsel patients on that. So I typically tell people once about 50% of your numbers are above target, either the fasting or the meal time. Usually that's when we're looking to start insulin. But again, every provider will have their own preferences and, always best to just talk with your provider directly.
Perfect. And maybe you can share the links to the videos with Joanne as well. And when she sends out the recording, she could attach the links to the video there as well.
Okay, I can certainly do that. All right.
All right. Thank you again for your time. We appreciate your help. And I will get this saved.
All right. And just wrap up here with the future lecture that we have coming. So thank you for everyone for joining us here for the evening round session. Hopefully this information was really valuable and will be applicable for your work and as you continue to help take care of all the patients that we see. Please mark your calendars for the next evening rounds. It's going to be on August 18th, where we'll be discussing endometriosis and adenomyosis. And the presentation will be done by Dr. Farah Alvi, who is one of our minimally invasive gynecologic surgeons. Thank you and have a great evening.